nursing. So, and thereafter did my post-graduation in Masters in Social Work. And here been in Pallium. I'm here since from 2017. I'm working in Pallium as a section head of the social engagement. So today we are going to discuss about the psychosocial aspects of palliative care. How these psychosocial factors which and the strategies what Talim is doing, and what are the kind of an academic disciplinary things which we are focusing here. So that is going to discuss here, because as we know, we both here the professional social workers and the volunteer social workers, we both are doing something for the benefit of the society and for the upliftment of human being. So how we can go through a proper strategy, a proper plan. So that is going to be discussed here today. And one more thing, the support system which we can provide to the community is different based upon our geographical area and the attitude of the people around us, the society's culture and the pattern. So maybe here in Kerala, the community participation maybe have some difference from your your area. So I can only tell you about the plans which we can provide, and how we can do a good kind of collective collection of information. That is we are going to discuss here. Okay, so I think you already aware about the definition of palliative care, which is an approach which improve the quality of life of patient and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems such as physical, psychosocial, and the spiritual. So when we are looking into the life-threatening illness, we can also include the life-limiting conditions also here, such as spinal cord injury, trauma, and so we are giving a comprehensive care for the seriously those who are having serious health related suffering. We are providing all these four aspects togetherly. We are covering that the physical, psychosocial, as well as the spiritual one. So what make palliative care centers have a kind of difference from other healthcare settings? So some of the elements are, first one is the patient and family. Here we are considering as a unit of care. So we are discussing to the patient as well as the family members about their present condition, what kind of illness they have, what kind of treatment strategies they are going to be. And for everything, we have a connection with the patient as well as family members. So each family members also, we are able to connect with each of the family member and identify what are their problems in relation with the patient's illness. So that is one of the major important factor which we are covering in the hospice care. And care is provided in the inpatient facilities, and those who need the care at their home, we are going to there to find them in their own home and providing care at their home. So that is one of the other specialty of palliative care. That means we are providing home care services. Then symptom management is the focus of the treatment. So we are not going to provide any kind of therapeutic treatment, but managing the symptoms which is associated with the existing diagnosis condition. So that is the major part we are covering. Then palliative care treats the person as a whole. That means we know that when we are going to a hospital, due to their busy schedules in their OPD settings, they may not able to look into our all things, right? So they may ask about their our pain, but they may not ask about our emotional pain. So like that, here but we are considering the person and not as a patient. So thinking about what the patient is suffering from and what are the situations they are going through. So all kind of things we are looking into that. Then services are available here 24 hours a day, and palliative care is interdisciplinary, which means so lot of professionals are involving in the care of one patient. Even they are setting their own professional standards for make a person's quality of life improve, but have a together meeting, and they are setting a common goal for what kind of care we can provide to improve the quality of life. For example, if a social worker is going to visit a patient and understand that the patient is in a severe depressive condition because he's not able to anything in her daily life, and what a social worker can alone, they may not able to do anything, and may physician may also may not able to do alone anything, but and the involvement of a physiotherapist in that team, and maybe that may be their plans for that patient care may be set as the first priority, because we need to improve the activity of their daily living setting. So how we can able to help them to improve their activity of daily living, maybe how they can hold a spoon for taking the food, and what how we can help them to make their life somewhat easier. So that is the first priority we are setting us together, that it is a importance of interdisciplinary team. So maybe sometimes the patient having lot of family conflicts and emotion, and because of that they are showing lot of somatic symptoms. That means the pain which is not there, but always feeling like she patient having a severe headache all the time. So this is because maybe because of their issues related to their family, and we need to sort out that thing first. So together, a group work is needed, and every day, those who are involved in the patient care is having a multidisciplinary team meeting, and in that all the persons are expressing their own concerns regarding the patient and set the goal based upon their overall assumption regarding the patient. Next is the volunteers are the integral part. So we cannot achieve anything without a community network, and for a community participation, volunteers act as a pillar between a palliative care unit or the palliative care professionals and with the community, and they can search about who all are the patients near to their neighborhood, and they can register that patient to the palliative care center. And the volunteers are acting as a pillar and act as a bridge between the professionals in palliative care setting as well as with the community. So we can say the volunteers are the integral part of it. And next one is hospice care is community based. As I told, the palliative care, as we are giving a care in their home, we need to develop a kind of network system to provide easiness of care. Some may not all the time the palliative care team can't reach the patient home. So we need someone there to take care of the patient, even for an emergency care or emergency transportation for the patient to the hospital, and any kind of support, we need someone there in their neighborhood network. So we are spreading it as a network, a kind of social mapping is doing, and identifying the volunteers and other professionals who are able to take care of the patients in their neighborhood. So we can say this hospice is a community based. And the other one is bereavement services. We are not stopping our services with the end of life of that patient, but beyond that, how this family is going to cope up with the situation. So that we need to understand, because sometimes the breadwinner of that family is a man, or the patient itself is the breadwinner, and the wife of that patient is may not able to go outside. She don't know anything. She is only doing what he is giving to the home, or what money he is giving to the home. She is making something with that, and she not able to sustain in that situation, and also she want to develop her children. So the family need to be more survival. So how this family is going to cope with the situation after the breadwinner goes, or the husband goes. So that also need to be identified. It is one of the major role of the volunteers as well as the social workers to identify how this family is going to coping with the situation. If the woman, or the wife of that bereaved deceased person is educated, how we can support her with her existing facilities, or how we can facilitate this family into the government as well as to the society. The reintegration of this family to the society is also very important. So how that will be happening? So there also the importance of social workers as well as the volunteers is very vital. So why the psychosocial care is important? So as you've seen in this circles, these all four aspects, the physical, spiritual, psychological, and the social. As we see, this one circle is overlapping the another circle. That means the problem is compounded everywhere. If there is a physical problem, definitely that may lead to some of the spiritual, psychological, and the social distress to that patient as well as to the family member. And that's why psychosocial care is important. Other than the physical aspects, all the social, psychological, and the spiritual needs we can able to provide, or we can able to take care of that. So how? So how? That is a question. And what are the important areas to be assessed? As I told, the social work, anyone can do a social service to the society in many manner. But here, we have to organize it in a professionalized way when we are doing a palliative care assessment or a palliative care services that I'm going to tell you in the session. So, what are the important areas we need to cover, and identify our priority interventions for the patients? So, how we can identify these factors? So, this is going to be discussing here today. So, the first thing is assessment. Assessment is an exploration process of gathering information about the person. So, how we are gathering the information? Through communicating with the patient as well as with the family members, right? So how we are going to explore the informations, and what are the informations we need to collect to know more about the patient and the family members. Then only we can set some kind of goals, and with that goal only we can develop some interventions. So these selection of goals and interventions depends largely on what is being assessed. So the first initial thing which we are doing is the assessment. And what is our aim? Aim is to identify problem area which result from illness, and which may influence the well-being of patient and the family members. So the problem areas means what are the issues raised after the illness related suffering, or in relation to the illness, what are the issues raised, then how we can resolve some of its factors and improve the well-being of that patient and the family. If that means, so the problem areas may be sometimes the patient and the family having some family conflicts that been from many years, there may be a problem. But the illness comes after that, or just after 1 or 2 years before. So it's not related, so we cannot able to assure that we can solve the problems that is happening since happening from many years, but we can only assure the problems which is resulted from the illness, or maybe the patient is isolated due to the disease condition, or maybe having some depression related to the insomnia. So these kind of things we are focusing, and how we can help them to improve their quality of living. So that is our goal. How this thinking process are going, and we can just we will show you a, no, Ananda, show you a video. So thereafter we can come back to the session.
बसतो ना कधी बसतो ना इथे ठेवा ना.
So as we seen in this video, there are a lot of different thought process for a patient as well as their family members and those who surrounding them. So how that assessment is taking care? So we know it's an ongoing process assessment because the psychosocial need of the patient, family, and the caregivers often change over the course of illness. So each time when we are seeing the patient, maybe their needs are different, but we need to prioritize what is our goal and how we could able to help them. Okay, so what we are going for do? So we are doing purposeful observations and purposeful conversations to know much about the patient and the family members for setting a different goal for the patient. So how that is going to be happen? Pradeep, could you please mute yourself? So how we are going to collect the informations? The informer may be the patient itself. So the primary informations we are collecting from the patient as well as the caregiver. Sometimes the patient is may not able to give this information. So we are depending on the primary caregiver. The caregiver in the sense those who are standing beside of the patient, and we never call them as a bystander. Instead of that, we are calling them as the caregiver, that the person who provide the care initially. So when we are taking the information, we have to collect it from the uh, initial caregiver, who those who are giving the medicines, those who assist them in their daily activities. So they may not, they may be able to give more relevant information regarding the patient, their physical as well as the psychological factors. So the caregiver is very important for getting the source of information. And the other one, collateral source. If the information is not sufficient from the patient as well as the caregiver, we are focusing their friends, their relatives, neighbors, and also the local bodies. So we are not only giving the physical care, but we are providing some social support also. So the information which is given by the patient and the caregivers is relevant, then if or it is not sufficient for us, then we are collecting other sources information. Okay, then sorry for the interruption in between. So what are the important areas to be assessed from the psychosocial point of view of total pain? As we saw, we are focusing upon that circles which I have shown. So we are considering all the physical, psychosocial, and the spiritual factors as a total pain. So we are providing total care for this total pain. So these are the important factors which need to cover when we are going to get more with the patient. Okay. So the first one is a patient overview, and second one, insight about, maybe it's about their condition, it could about their personality, so all over. then family overview, then socioeconomic overview, psychological overview, spiritual overview, and the psychosocial overview. So based upon this, the intervention and plan is developed. But this is a general thing, and follow-up assessment is also the part of our assessment. But this is the general factors which we need to get from the patient. And one point is the spiritual overview and the psychosocial overview is doing based upon the need. And the spiritual thing will be happens only after having a good rapport with the patient, maybe more than 2 weeks or 3 weeks. And the psychosocial overview is based upon the need only. If there is any kind of importance is there for that family, then only we are going to interfere into the psychosocial assessment. Okay. So the first one is the patient overview. It involves the basic demographic details. So why I'm telling like this, when we are going to visit a patient in their home, maybe you have a hesitation regarding how we are going to start the conversation. So we can start with their patient demographic details itself. Okay, so it involves the patient's name and their age, their occupation before and after the illness, whether they are working now or how long have they had worked, then who was the primary caregiver and the relationship with that patient. So this is a general thing. So is that clear? So basic demographic details involves the name, their age, their sex, and the occupation before and after the illness, who is the primary caregiver, and the relationship with that patient. Maybe the primary caregiver is a paid one. We can understand how that patient's psychological, the factors may going through, and where is the family members. Maybe all the family members are staying abroad and only the parents are staying in the home, so they're obviously having some kind of loneliness and a lack of social support. So all these things we can assimilate with the kind of informations providing by the initial talk itself, and who depending upon who is a caregiver and the relationship thing. Then next is the insight in the sense, insight about their condition, about their prognosis, and insight about the palliative care also, which is very important in our, when we are giving a palliative care team approach concept. It is very important to understand whether the patient as well as the family members is aware about their condition or not. I think the communication session is over, right? Yes. Yeah. So you already understand about how the importantly the repeat we can avoid the repeated questions and breaking the bad news with the patient, even if the patient is not aware about the exact disease condition, and suddenly when we are going to the home and telling about what the patient is suffering with, so that make a huge trauma in that family, and having lack of that emotional bonding with the palliative care team and the family also, and how much information regarding this patient is hidden by the family, that is also to not at all understand. So these all things will be exactly we will get this data with this information, what patient is aware about their condition, what is the current status, and what is the future prognosis, and whether the patient is aware about what palliative care is, because there is a stigma is in this family regarding that palliative care is giving the patients, those who are having terminally illness. So sometimes the palliative care team approach the family, the patient itself having some fear and anxiety regarding there is nothing can be done much better. So that's why palliative care team arrived at our home. So I can, there is no hope for me. So this is the thing maybe happen. So we have to understand what the patient and it happens with the family members too. So we need to know much about what their understanding about their palliative care and the disease condition, and which will help the team also to avoid repeated questions also. We can see like those who are not attending the volunteer programs, they may directly go to the family and asking about the condition of the patient. So how we are going to, what about the radiotherapy and chemotherapy, everything they are asking based upon they have a concern, but they don't know what impact that to the family and patient. So this is very vital thing. We need to take care really about what their understanding about their exact disease condition. Uh, and we need to have an idea regarding what palliative care exactly, which is not that there is nothing more which can be done. So that is a kind of myth is existing in the society. Palliative care can be provided from the beginning itself of the disease, and it is very effective in the pain management as well as the symptom management, and is not always for the terminally ill patients. And the other thing, next point is the family overview. So we understand about their what the person is, and what their exact condition. And next we are going to look into their family overview, which involves the genogram, family dynamics, that means the support system and history of illness in the family. So what is genogram? So it is a pictorial representation of person's family over at least 3 generations, which tells us about the structure, dynamic, strength, and the resources. So the type of informations could be their name, age, education and occupational profile, and emotional relationship. So it is very effective one, which we can use in our patient, the clinical records. So we can avoid the repeated questions, and widely with that picture, it is a pictorial representation. So we can, it is very helpful for us to understand the wall about that family. So these are the symbols which we are using in that. Who is a male? Male is with that square, female with the circle, and marriage means there is a one single line. Separated means a slash. Then divorce means a double slash. So if you Google it, you will get a lot of symbols in association with the condition of the patients, as well as the structure of the family. So these are some emotional relationship symbols. We can add some, if there is an intimacy, we can mark it as very dark, or as you see, double parallel line is there. So friendship, how can we represent? Even if it is not, you can do something as your own and mark it as a legend near to the that pictorial representation. Okay. And the next one is the echo map. Echo map is a pictorial representation of patient and family in its social environment relation with the larger society. There we are first focus upon the family system, how the family and the family system is working. Here we are focusing upon how the support system is working. That is clearly related to the family. Here it is related to the society. So ECOMAP is also a pictorial representation of patient and family in its social environment. So how the relationship of this family with the society. So which is a snapshot view of important interactions of the patient and a family with other systems, such as extended family, individuals, organization, association, etc. So ECOMAP is very relevant for the volunteers to identify what is lagging in that family and what kind of support system can be developed as a volunteer to that family. So it is very vital. And see, as the family is concerned, what are the support system. Examples of them are school, health service, extended family, friends, neighbors, workplace, local services, clubs, religious institution, where they have a good relationship with these all things. You can add what if you are visiting a family and identify any kind of hospital is nearby that family, or any resident association that we can able to connect with them, or any school or school teacher, like that we can understand whether what kind of support system is available in their existing condition, that as a volunteer we need to develop, or we need to collect, communicate, or connect them with that particular resource. Then only they can we can develop a network there, and they have a good bonding can be provided to the patient with that community. So the next one is the socio-economic overview. The socio-economic overview, in the sense, it is very important for kind of, as we are doing social service, if even it is in a trust or any NGO or any society, we are maybe we may plan for much kind of support system we can provide it uh, by available funding sources, or with the CSR projects, or with the grants. We are collecting lot of or we are raising money for giving for the genuine one. So those we have to provide it in the correct person. That's why we are assessing the socio-economic status. At the same time, those who are very poor category also need to be identified, and that support we need to be provide. Should a volunteer mention that they are from palliative care unit, as it may convey a wrong meaning? I got a message from Michael. Should the volunteer mention that they are from the palliative care unit, as it may convey a wrong meaning, Michael?
Yeah, couple of slides before you had mentioned that the palliative word conveys a different meaning for different people. They may think that it is the end of their life just because a volunteer has come from palliative care unit.
Yeah, that's why we need to, so that is the first point. We need to identify what the insight of that patient. Sometimes the caregiver comes with us and registering that patient. So we have to ask them whether the patient is aware about, is as we are coming from, so they are going to register for the palliative care unit, and the palliative care volunteer or the persons from that unit may comes or not. So we have to get an idea before itself. Otherwise, in the initial conversation, before we can say that I am Michael, I'm coming from this place. And before that, we have to get an idea from the family members or those who are connected with us now. We have to get an idea whether they are aware or not.
Okay.
Okay, even the patient is going to cope up with the future facts, and we are going to take care of them. So anyway, we have to convey that I'm coming from a palliative care unit, and what palliative care is. That's why we are asking what's your understanding about palliative care. Maybe they may tell to us, we are not going to tell that, oh, this is palliative care and we are providing these kinds of support. Instead of that, in the initial talk, we have to ask what you know about palliative care. So based upon that assessment only, we will provide more information to them.
Okay.
Okay, sir.
Okay. Thank you.
So what are the relevant informations for the socio-economic overview? We have to get idea about whether this patient is having adequate food, cloth, and shelter, or having the basic amenities is there in the home, who is a breadwinner, who control the finance, who is a source of the information, who is a source of income in that family. Sometimes the breadwinner stays abroad, who is the decision maker of that family, and we have to identify what kind of source of income is receiving. it could be from the government, or it could be from the relatives, or from the friends, or from the family itself. So what about the debt and the social support system? What are any kind of pension is availing in that family? Maybe widow pension is there, cancer pension is there, lot of pensions is available as per the state government policies. So we have to ensure whether any kind of that kind of support system is there. If it is not there, that is one of the role which we can involve. We can facilitate that government support scheme to that particular family, and the education of the children. Many of the persons, children may have discontinued their education due to the overburden of this family, or is any kind of threatening is there for the children to stop their education is there or not. So that is also need to identify. This is initial things which we need to observe and collect, and also we need to sure that what is the income and what is the expenditure. The income versus expenditure, when we are looking how it is tackling. So the income is very less and the expenditure is so huge. So definitely the family having a huge debt or nearby future itself also. So this is the fact we need to initially collect about the socio-economic things. So based on the socio-economic assessment, we can provide a lot of support system for the family. As we told, so the breadwinner itself is a patient. Then how we can support the other members who comes as a future breadwinner of that family. You can see in this picture both that men in the first picture and the women in the second picture, both are paraplegic, and they are trying to develop new skill for coping with the situation and how to survive in the future. So that kind of ability, that kind of training which we can provide, how this vocational training based upon the initial assessment about the socio-economic factors and ensure that the patient belongs to the very poor, middle and high class category based on the assessment. Then we can plan what kind of support system is helpful for the family. A high class person may not need vocational training, but they need a social support for maybe physical support, not a kind of nothing regarding the economic thing, but a social support, maybe for the transportation from the hospital to the home, as well as emotional support. But a very poor family also need a kind of vocational training or vocational rehabilitation for their sustainability. So these kind of things we need to assess, and it is one of our major role. We can do fundraisings, we can do collective work to make this happen. So some of the pictures shows like this is a petty shop which we provided for those who are not unable to go from home to anywhere for the job. So we can give a petty shop to them. It depends upon the social factors as the and the sustainability of this rehab is based upon the interest of the patient and the family, as well as how is it sustained in their that particular area. See, goat rearing, chicken farm, poultry farming. So these are some other assistance volunteers can be provided, that by providing food kit and providing physical aids and giving assistance to the palliative care team members. So a lot of things as a volunteer we can involve. Here in Pallium, we have different committees. As it is a trust, we have different committees which they volunteers are doing an integral part in that. Most of the committee members are the volunteers from a different area, and they are assessing whether this patient is genuine. Once a social worker is assessing and providing a report, based on that, a secondary level assessment is doing by the volunteers. So based on their conversations and the observations and information collection, they are also analyzing whether this family needs a kind of support. It is a food kit. First picture showing we are distributing the food kit to the patient's home. So whether a food kit supplement can be provided and what kind of support is needed. Different committee is there. For the vocational rehabilitation, we have a committee. Food kit arrangements, we have a committee. Bereavement support, we have a committee. So volunteers are the very vital part in all that. Like the same wise, also as I told, those who are lagging the educational support, because most of the children who are in that family may be neglected because of the serious health related suffering in that family. So we can act as a volunteers can act as a mentor for that students, and you can do a call after this. Okay. Can anyone mute? Okay. Okay. So you can act as a mentor for the students of your patients, and we can arrange a summer camp for them, because there may be no one from that family. The parents may not able to take this students into an outside world. So here these volunteers are organizing a summer camp, which is a 3 days program. It is having career guidance and many recreational activities and motivational talks and 1 day outing also. So these all one volunteer having more than 3 to 5 students. They are regularly contacting their teachers, class teachers, and making a report of their assessment, monitoring their education, and evaluating it. Based on that, what kind of life skills as well as mentorship can be provided. So this is also one of the major tasks which here we are doing. And also in bereavement care also we can provide that kind of support. We can here we have a group called UNNER. In that, the bereaved person's family members are meeting together twice in a month with the support of volunteers, and volunteers are assessing whether this family is coping with the situation, how the sustainability is going on, and what kind of support we can provide. So they are facilitating it with the Pallium India. So we are getting that kind of collective information from the volunteers and assessing them and help them to get a sustainable source of income. So I'm added the psychological overview also for a general understanding for you. So how when we are identify the patient or the family is overwhelmed, helpless, and showing hopelessness, feeling guilty without a clear cause, and they are showing very much of worrying and anxiety, and having disturbed sleep pattern, changes in the appetite, isolating from people or activities, experiencing unusual anger or irritability, fatigue, having difficulty keeping up with their daily tasks, and having a lot of somatic symptoms. If the caregiver identify this and inform to you people, or you itself identifying them, have to definitely inform with the palliative care professionals, so that we can avoid kind of maybe they may go to the serious depression. Thereafter it comes into a disaster. Maybe the patient or the family member may committed suicide. So we need to avoid that. There is a proper involvement of the clinical psychologist, social worker, and the psychiatrist is required. So we have to identify the patient or the family member is suffering a complicated grief over there. So how we can identify? There is a normal or a regular copy mechanism of each and every person. We know after the death of loved one in that family. Anyway, as a human being, we have to coping with the situation. Other family members may go after at least after 1 month, they used to do their regular activities, right? But instead of that, they are not doing anything. They are sitting in a room. They are not speaking. They are not doing anything, activities which they are doing in the past. So definitely there is a complicated kind of coping resistance comes. So this is need to tackle. So these kind of things we need to identify. The same like when a person is identified as a patient in that family having a chronic illness, or the family member it's showing like these kind of any complicated issues, that is also need to identify. That's why I told these points is some initial things which we need to identify whether any irregularity in this pattern is or not. So next one is a possible social impact. This is the thing which happens mainly for the patient as well as the family members having social isolation and increasing the dependency. As we can imagine, some person they are not at all depending anyone in that in their family for anything, and they are having a good source of income and a good employment, everything. But suddenly are met with a stroke and depending the family members for each and everything in that daily living activities. So how we can't explain the situation physically as well as what that person may going through. So the dependency, that is also a very big tragic factor. And financial instability, lack of social support, debt, loss of work, interpersonal issues, inadequate facilities. So, and moving to the next thing is the spiritual assessment. As I told, it is a complicated thing which we not able to ask or doing with one or two kind sittings. And the spiritual assessment is doing for the patients who having a rapport more than 2 to 3 weeks at least. So what are the major factors which we need to cover in the spiritual assessment? When we are hearing that word spiritual assessment, we may think it's always connection with the God. Always the spiritual thing is some priest comes and doing some kind of worship or something. Lot of assumptions is there with that spiritual care. But the thing it's actually we have to identify with the spiritual assessment is how the person is, and we are overall assessing the person as a person. Means we get a chance to look into what am I, so how I connected with others, how I connected with my family members, um, who was my best friend, who is my best friend, who stands for me, to whom I have a strong connection. Even so this is basically we are applying with the persons having end of life care. So this session will help us to identify a clear idea about the individual person, and we are providing them a kind of um, an opportunity for them to look back to their overall whole life. So that is really wonderful thing which we no one is asking questions like who is your best friend in your childhood, which school you were studying, what was the happiest moment in your school life. So when a person is in an end of life, or if he could able to speak, or they are in extreme distress, or and I mean emotional distress, not physical, and having a lot of loneliness, we can take them into their all past life, and obviously there we could able to get a positive thoughts, positive outcome from their what they gain from their life. So it is overall the meaning of their own life we are identifying. So what is the meaning of their life? What is the happiest moments in their life? Maybe it is their wedding, or maybe having the first child. That was the glorious thing in their life. And what is the strength in their family, or what is the strength in as a person, who what gave them comfort, what their connection with the others, with the universe. So everything we can ask in that, which is something complicated, can be done by a professional. And what about the hopes and concerns? So this hope and concerns involves, indirectly we are asking about the what is your last wish. So that is also one of the thing which include in that, what you hope for, and what is your concern. So what you want to do for the next weeks. So something like that could able to get some beneficial answers, like they want to celebrate this thing, and they want to go to visit a beach, or they want to go to a hilltop for so a lot of that kind of stuffs we may get. And this is really interesting and helpful for us, as well as the person to know more about what they gain in their overall life. So at a one word, this is a kind of mood change which they may get with this spiritual assessment. So this is a picture of a person who was nearby his end of life, celebrated his wedding anniversary, and this was taken out after and a spiritual assessment. He said after 2 months, his wedding day may come, and he may not be there for celebrating that. So in hospital inside itself, it was celebrated in advance. So you can see the smile of that person. So that kind of last wishes also we can get it from the spiritual assessment. And the other one is the psychosocial assessment. The psychosocial assessment is, as I told, it is Vivo 1917. So the psychosocial assessment is doing for the, basically we are doing for spinal cord injured patients, because after becoming a paraplegic, they may not able to do their sexual function properly. So if it is a young couple, they have to go in their future life, and the couple may require a child, and it is not able to get from that particular person, or he is not able to do that. So these kind of things, whether they could adopt a child from somewhere, or any other facilities with that, they can do it in any kind of treatment can be possible. This can be maybe without a practical informations, or without a guidance. Sometimes this couple may not be thinking about that, how maybe the husband thinks, how I can ask about all these things to the wife, and she is also having the same thing, and they may also having the sexual desires too. So that is also a kind of kind of guidance is required professionally sometimes, if they are struggling with that. So it is a kind of gender biased, but the psychosocial assessment is doing for a male person. Here, a male social worker is doing, and for a female, females are doing, to get more collective informations without any hesitation. So based upon that, we are giving a proper psychosocial assessment. And if any kind of medical assistance is required, definitely we will consult them with the specialist. So that are the general things which we need to cover in a strategic plan. What are the things overall we have to look into? And our general interventions involves family meeting, psychosocial support, facilitating psychoeducational support groups. There volunteers are doing an integral part. recommendation for government schemes and other financial assistance, linking with the community resources, vocational training and rehabilitation, and regular follow-up. So linking with the community resources is one of the major thing which volunteers can be effectively, they can do that. You can map what kind of services are available within your society and in your community, as well as with the local government or the state government facilities. So if you get a kind of idea, you can definitely connect them. You can facilitate that kind of support system, and you can stand for that patient and tell that as I'm a palliative care volunteer and this support is necessary in this family. So you can facilitate this kind of support system with your initiation. So and the vocational training and the rehabilitation also. You can togetherly plan it in if you are there are a lot of caregivers is identifying in your particular locality, arrange a training commonly for that caregivers for a day, and assign someone for taking the initiatives, and definitely we can give that kind of training support. Some training, the when we are giving calling some poultry farming experts for giving that kind of what kind how the poultry training can be done, they are also giving some materials also, maybe that cage and at least 5 or 10 hens for them, so them some free in additionally they may give. So we can identify some beneficial business people for that and connect with them. And regular follow-up is also necessary when, because we have to develop a bonding or emotional bonding and a trust with that patient as well as a family member. So if we are not doing a follow-up, once we get any kind of concerns raised by the patient or the family member, you have to tell them that we will get back to you after consulting with the palliative care team. So we are not there for giving all whatever the questions, we are not able to giving all the correct answers. But anyway, those we if we don't know and if we don't know the correct answer, or if they are asking some truthful questions, we can't able to give a false hope regarding something. So that we have to clearly careful for that. And also we have to respect the caregivers. That's why I told we can't able to call them as a bystander, because the caregivers are very integral part of a patient care. So they are, they are an invisible patient in that family. Mostly it may a woman who is not at all taking care of their health, continuously taking care of their family member. We know now, we can experience it in our families. They may not take adequate medications. They may not, they always neglect about their own health issues and taking care of their kids and husband. So mostly caregivers are women. And as Rosalie Carter tells, there are only 4 kind of people in the world: those who have been caregivers, those who are currently caregivers, and those who will be caregivers, and those who will need a caregiver. So we all need caregiver, and we all may become a caregiver. So respect those individual and acknowledge their complex role, and never dehumanize them by calling bystander. Consider them as a person. They also having that same emotion that what is going to be happen to my loved one. So we need to acknowledge that. We need to understand that. So we have to respect them. How that dignity, we have to conserve a dignity of care to the caregivers with our attitude, our behavior, our compassion, and our dialogue. Okay. Before moving to the next slide, we can watch a video.
Today, we see around us many bedridden patients who have lost hope for a better life. Abandoned by conventional medicine systems, they live their lives dependent on the care of their near and dear ones. Globally, 80% of this care is provided by women. Often, women caregivers neglect their own health and well-being in the care of others. Families also fall into extreme poverty because of the illness of the main income earner, the male. Dependent women are left without any means to survive. The Pallium India Trust recognized this crucial need for women caregivers to be supported. With the financial help of the Women's Wing of the Federation of Malayali Associations of America, Pallium India Trust is extending a helping hand to one of the most neglected sections in society, women caregivers. Shaila has faced misfortune upon misfortune. While her husband was stricken by cerebral vascular accident, she lost her 22-year-old son in a motorbike accident. Despite these debilitating events, Shaila faces life with unusual courage. Once again, Pallium India reached out and is supporting Shaila to rebuild her life.
Pallium India, അവരെല്ലാവരും ടീമംഗങ്ങൾ എല്ലാവരും എനിക്ക് ഭയങ്കര സപ്പോർട്ടീവാണ്. ശരിക്കും പറഞ്ഞാൽ ഞാൻ ഇന്ന് അങ്ങോട്ട് മുന്നോട്ട് പോകുന്നത് തന്നെ എനിക്ക് അവരെ സപ്പോർട്ടുള്ളത് കൊണ്ടാണ്. എല്ലാ രീതിയിലും എല്ലാവരും ഭയങ്കര ഇതാണ്. എല്ലാവരും എൻ്റെ അടുത്ത് പറഞ്ഞിട്ടുണ്ട്, ഏത് സമയത്ത് എന്തൊരു ഇത് വന്നാലും ഒരു കോൾ ചെയ്താൽ മതി, അപ്പം അവരെത്തുമെന്ന് പറഞ്ഞിട്ടുണ്ട്. അത് തന്നെയാണ് എൻ്റെ ജീവിതത്തിലെ പ്രതീക്ഷ.
Vijay Kumar and Vijay Kumari are siblings affected by an autoimmune disease. Now, at 34 and 36 years, their only caregivers are their elderly parents. While Pallium India provides them with home care facilities, which takes care of their medical needs, their elderly mother needed an extra income to support the family. ₹30,000 was given to Jainamma. She continues caring for the children from home. Rashmi has another story to tell. Her husband Biju is confined to a wheelchair after a spinal injury. Rashmi set up a small garment business with which she managed to run the household. But the huge costs of the medical treatment for Biju and subsequent deaths forced her to stop the business. Through FOMA, She was given a grant of rupees 30,000. With this, Rashmi was able to restart her small garment business. Loneliness and helplessness are one of the biggest challenges of old age. 60-year-old Sarojini Amma and her chronically ill 70-year-old husband are facing this problem. A small tea shop is her means of earning a livelihood. Pallium India, recognizing the need to help her with more vessels, etc., became the ray of hope in Sarojini Amma's life. We have just seen 4 stories among the many that the Pallium India Trust has affected through timely aid and care. These women devote
So as I told, we cannot neglect other women caregivers and those who are supporting, whoever it may be, the primary caregiver of that particular individual. They are very important. Their physical as well as the emotional status also need to be considered. So we have to conserve in ABCD that our attitude, our behavior, our compassion and dialogue, which reflects a good kind of empathetic approach with the patient as well as the family members. So these are the general interventions that the psychosocial teams doing. Information collection, listening with the patient, family member, and with the society, also with the community, then regular follow-up, psychoeducation and facilitation, counseling support, rehabilitation, whether it is physical as well as the vocational, then bereavement support. So these are the general interventions. And when we are doing these all things, we always evaluate our interventions. We assess how the patient and family is benefited and how the assessment have to be revised and updated. So then good documentation is also valuable one. Wherever possible, use research validated techniques, and there is an art and science in psychosocial care, just as in the medicine. So we all here for giving such a kind of a social care for the patient and family. That's why you are here. So these are the things we need to remember. So this is about the psychosocial care providing for the patient and family, that strategic pattern following in Pallium India. So as I told, it may vary, depends upon your community and the society's attitude and the support system within your existing area. So we can move into the discussion. So if you have any doubt or want to share your own experience in your particular community, so we can discuss over here.
You can either unmute and speak from your end, or you can use the chat box.
Any doubts or you want any more clarification regarding any of the things which we discussed? Is it possible to provide a list of local palliative support groups in Hyderabad? Yes, Manjusha.
I reside in Hyderabad, so if you have a list of organizations that already do palliative support with whom we can volunteer, that would be very helpful.
Ma'am, we will share it through the WhatsApp group.
Okay, thank you. Thank you very much.
Just a clarification, when you say bereavement services, it means helping beyond the bereavement.
Sir, we can't hear you. Can you make it more louder?
What I was saying is that, can you hear me now?
Yes, sir.
Okay. When we say that bereavement services the caregivers give, is it beyond bereavement or just on bereavement?
Is that?
Is it extended beyond if somebody dies in the family? So
Yes.
we give care beyond the death also, that is post death, whatever support is required.
Yes. After the means after post death also, that only we told. After the death, we can provide a lot of services to that family. So first thing, there is if they are not clearly educated about the death certificate and all, we can ensure that whether they received the death certificate for the family, which may useful for them. Here the death certificate is useful for if they are taking any loan for this for that treatment purpose and all, they can show it and get subsidized means low rates interest also there in that loan services and all. So that is one of the thing. And also, as I told, how they are coping with that situation, whether there is a complicated grief is in that family, or who is the next breadwinner, whether they are able to go for a job, or is any sustainable income is there, any support system is there, any threatening issues is there. So everything, that's why we are continuously do a kind of follow-up with that bereaved person and understand whether the family is coping with the situation. Once the things get settled and they are telling, yeah, we are okay, and we are doing our job regularly, and children are going for the school and everything is settled, then we can withdraw our support system. Until if there is not a sustainable income, we can the volunteers itself, we can make it as a group, and we can involve them in that. At least we can able to give motivational speak, and some of the programs also we can arrange vocational training, or some kind of economic support through some agencies, something like that. Many things we can do like that.
Okay, thank you.
Any other doubts?
Any of you are doing currently any palliative care services in your area? Any of you? Or everyone are new? Yeah. Okay, did you learn anything new information from this session? Which we, and in some of the minute things which we neglected in our entire, collecting informations from the person, whether it could affect, effective for your individual skills also.
I find the entire thing knowledgeable because this is part of education in any family or anybody whom you meet, whether the person is having any illness or not. How do we relate to a person? All these things are useful, especially this collection of information. We do it very unconsciously. In today's world, many people don't ask or are not involved in each other's life. They don't ask these questions. They don't get involved at all. So I find this is very useful in our everyday life also, apart from palliative care.
Yes, sir. Thank you.
If there is no more questions or comments, I think we could wind up the session. Thank you all for being here. Thank you, Reshma, for this wonderful presentation and your valuable time. I'll be sharing the feedback link with you on the WhatsApp group. Everyone, please go through it, and we value your feedback. Please go through it, fill it up, and thank you all once again for being here. And I will see you on the next class. That will be on the next day. Until then, bye. Thank you
Thank you
once
all.
again.